Okay, awesome. All right, it looks like everyone is back. Okay, Aaron and Molly, I'm going to turn it back over to you all.
Great. All right, we'll go ahead and get started on reporting back out. So we'll go ahead and start with the mental health team, and I believe that Dr. White's going to present what we discussed.
Sure. Kelly, Lubna, Aaron, we were talking about mental health and different ways that we can, support change. And so one of the things we had discussed is, as it relates to our community health workers and our peer recovery specialists, that Aaron had shared that there are some plans in foot to help support them in various ways, everything from better pay for peer recovery, so they're not constantly moving on to other jobs, to also finding ways with Epic builds, as far as billable services, to take credit for what they are doing in the community, to help support them. So I think that CHWs and also our peer recovery specialists and our community health nurses, there's so many other ways that we can continue to help support them. Other things that were discussed. In terms of reaching patients, we discussed how there may be some difficulties with moving patients, that at different levels of care, that sometimes patients need very acute care and they may get stuck with a provider for a period of time. And maybe in time, as they stabilize, they no longer need that level of resource. And so very involving social work and other services to help evaluate this and help people step up and step down into different levels of care. And that may help us with our resource utilization. In addition, Kelly, especially, we had talked about kind of some like interfaith networks, different places to reach patients, the different community areas where the CHWs can go. And cognitive behavioral therapy, are there ways that we can both kind of like how we used to have the wellness network, and now there are different platforms. Can we kind of build cognitive behavioral therapy things where people can use their cell phones and on different levels, advocacy in state and government for trying to get billable services for telephone. If for some reason we can do telepsychiatry by telephone in an area where maybe internet connection is not good, and reach people through that, and also be able to have educational modules and things like that through cell phones and things. So I think that was a lot of what we talked about. Aaron, Kelly, Lubna, any other thoughts?
Nope, great job. The next group is socio and economic factors.
Yep, so I've been tagged to discuss what we talked about there. And so our general discussion revolved around the fact that Carilion actually has implemented a ton of amazing resources across the spectrum that can be accessed from all of the different service lines that we represented, which include family medicine and OB and myself in the emergency department. But the common consensus was that these resources are underutilized, either because of a difficulty to access or a lack of awareness. And so we felt that the kind of the goal of increasing resource utilization within these existing elements, rather than coming up with something new, would be to increase accessibility through some way or another. And one easy target would be increasing awareness at the provider level. So for the physicians, NPs, and nurses even, and even some of our ancillary staff, like for the emergency department, the patient service representatives who spend a lot of time in the room with the patient, and just so increasing awareness and then streamlining processes to help patients enroll in these things. And so one example of that would be, Dr. Kidd was talking about how he has these great community health resources at his clinic in Southeast, but in the hustle and bustle of the day, the physicians and resident physicians often forget to engage that person. And so having some sort of baseline process by where, perhaps patients are identified as needing these additional resources, and they have preemptively scheduled community health appointments on top of their existing appointment with the physician. And so really, it was more of a bravo to you guys for everything that you've put into place already, and trying to brainstorm ways that we can increase implementation and utilization of these already like fantastic community resources that from our perspectives are being underutilized currently.
Yeah, and Dr. Moore, you hit on two issues that we're trying to address. I know we only have about 5 minutes left, but if anybody has any ideas on how to increase awareness with providers or different meetings that Molly, myself, or our peers and community health workers could come and talk about their work, we would love that. And that's actually one of our goals for FY22 is to increase our integration and awareness with our clinicians. So we appreciate that. And last but not least, primary care. Who would like to present from that group?
I can present. We didn't talk about who would be discussing what we talked about. So one of the goals that we discussed for primary care would be really access to primary care for those who either don't have a primary care doctor, for those who have no lack of insurance, for those who are refugees or asylum seekers. There's a lot of different reasons why people do not have a primary care doctor. Some of the resources that are currently out there are, the Bradley Free Clinic, charity care for patients who don't qualify for maybe like Medicaid or other HCA programs, community health workers, the Rescue Mission Clinic. Those are already strategies that are, or community partners resources that are already in place. Some of the strategies we talked about for a lot of, we talked a lot that high utilizers of the emergency department are probably people who don't have a primary care doctor or who don't have easy access to their primary care doctor for one reason or another. And so, and also Dr. Luchtong also talked about with surgery patients, he's recognizing a lot of surgery patients don't have a primary care doctor to kind of oversee and manage their care. And that's an area we can definitely improve upon. And so some strategies that we came up with were, in identifying patients who don't have a PCP for whatever reason, we can have a nurse navigator, whether that's from the ER or they're inpatient or in the different specialty clinics. You can put like a referral in and they would directly call the patient and set them up. Instead of just providing them with a list of PCP providers in the area, they would directly call them and figure out what's the barrier to PCP access. Is that lack of insurance, and what are the resources for them, and how can we directly get them access to that? Or is it that they just haven't set up a PCP and then get them a direct appointment? We talked about nurse case managers while patients are in the hospital, really utilizing them to make sure there's a primary care doctor and a follow-up appointment. That just put that in there. And then also like a single web page, maybe on our intranet for these people who are, how to find where to enroll somebody in one of the HCA programs or Medicaid, and having a single page that kind of can help people navigate how to get access.
Thank you. Those are great ideas. Well, I hope that this activity was fun and got you thinking. Seriously, if anybody would like to get involved with this work or learn a little more, email either Molly or myself. We'd be happy to partner with you. But we appreciate the time this morning. And Molly, any final words before we turn it back over to Sarah?
No, I've just appreciated being here. You guys have been a great audience, and it was really interesting to listen to your conversations and hear your perspectives. So keep up the good work.
Yes.